Yeah, there's a person.
Dr. Dinesh, you can ask your question.
Yes, sir. Good afternoon, sir. My question is to Dr. Neha Mishra, sir, regarding infection control.
Yes.
I have already posted the questions in the chat box also.
Yes, very much.
Very clear.
Loud and clear.
Yes. This is regarding the N95 masks, sir. There are many types of N95 masks in the market, and those apply to us also. So, at a stretch, for how long can we use the N95 mask and the personal protective equipment?
N95 mask has to be, if it is a genuine mask, certified, it has to be certified by what we call as
NIOSH
certification. That is point number one. Any mask N95, once you put it on, the protection is roughly to be around 2.5 hours at a stretch. Third, always mind and take care that the material of the N95 is made up of glycopyrrolene. Therefore, very exquisitely sensitive to ultraviolet. So be careful when you are working outside, say sunlit areas with a N95. And that is, I think, one of the important things. Second, and the most important is the outer surface of the mask is to be treated as if it is very infected. Therefore, a proper doffing and donning sequence has to be observed. In other countries, a meticulous mask fit test is will always be done. I think in our country also we can attempt. When a mask snugly fits you, somebody can spray, perfume or so 1 meter away. If you can still smell it, then the fitment is not accurate. This is a very simple way of fit testing the N95 mask. The other rule, ICMR has given a tabular rule of where to wear a N95, where it is not required. So any direct patient contact, you can wear N95, especially if there is aerolization and other things, other PPE is also required.
I don't know how many of you have worn an N95. If you wear it properly, I have worn many times. You will not be able to breathe for more than 30 minutes. It is very suffocating if it is properly worn. And there is no need to wear N95 and go around the city. There's an acute shortage of N95. It is highly irresponsible even of doctors to wear N95 and go around. N95 is meant for frontline emergency medicine staff who are receiving patients whom we do not know whether they are COVID or not COVID. Till they segregate, we will not know. N95 is required for people who are managing COVID patients. Other than this, N95 has no place anywhere in society. I hope I am very clear on this. Removing is always never do anything in the front, always from behind and carefully put it into a yellow cover bin.
And before and after hand hygiene, yes. Dr. Ravi had spoken to you about specimen collection. So when you are taking nasopharyngeal swab, he had clearly brought out the point that patient there is a high chance of sneezing and aerolization. Therefore,
so all the people
N95
who collect specimen should wear full PPE and N95.
See, we observed so many times those people who are using N95, they are touching the outer surface. That has to be avoided.
Yeah, touching the surface.
And once you remove it, it may not be good to put it back again.
Yeah.
Because the fitment will again go up.
And our request is not to go by social media at how to re-sterilize and other
things. Please don't recycle any mask.
Unless and until there is a clear-cut ICMR kind of guidelines.
Instruction, validated procedure comes. Don't believe what is circulating in WhatsApp University. In WhatsApp University, everybody is a professor, everybody is an expert, common man is casualty. So please don't, there are so many fake things that come unless there is a guideline on WHO website, Ministry of Health website or ICMR website, whatever comes in social media, do not accept it. We are all professionals. We should be responsible for filtering information. Authentic information comes only in these three sites.
Honorable VC has asked me to talk a minute about disposal of N95 and removal, doffing and donning sequence. Simple thing, first perform hand hygiene before you even think of taking out. The simple principle is 2-glove method. If you are following, use the outer glove, take off the outer glove, perform hand hygiene on the inner glove, take out the most soiled piece first before coming to your mask. In the mask, lower strings are to be taken out, and as Dr. Ravi said, from the occipital side as much as possible. The mask should come off in one go, and do not touch the outer surface. Now the mask has to be put in the yellow bin and immediately perform hand hygiene. Once that is done, you would have almost reached complete removal of PPE. Please do make sure that hand hygiene is followed with water and soap, even if you have used a sanitizer. In your sari units, insist that there is a foot pedal tap, soap, and next to that a disposable sanitizer kept ready. Next question, please.
How to dispose N95 mask?
It goes to the yellow bin.
It is available.
Hello,
Because we have seen so many people, they are using and keeping their pockets, and repeatedly they are using. That has to be avoided. That is not at all advisable.
And once you take it out, you just have to discard it.
Discard
You have to put a new.
It has to go, when you remove the mask, there is only one place it goes.
Yellow.
That is yellow bin. Nowhere else it goes. And mask is not a fashion statement, especially N95. It should not hang on your neck or sit on the forehead. Once it's removed, it goes only to yellow bin, which has a lid, not an open yellow bin.
Any other questions?
Next question, please.
Yes. So one more question related to N95. Is there any alternative for N95 mask?
No, NIOSH certified N95 has no alternative. What does N95 stand for is that
95%
of
protection
the protection.
against droplets, not against gases. Okay? The N95 is a mask that protects against droplet infection in droplets of 0.3 to 0.5 microns. It will not allow to go inside, and 95% of it will be filtered. That's what it means.
They should not be under the impression that is 100% protective rate. That has to be kept in mind.
And Honorable Minister also has mentioned that personal protective equipment will be procured, and the situation is quite lucid. It is improving day by day. We hope there won't be acute shortage.
Any other question?
Thank you, sir. So one more question related to protection. Like, is HIV protection kit adequate if PPE is not available?
Is HIV protection kit adequate when PPE is not available?
Depends on what you are meaning by HIV protection kit. But just to summarize, the full PPE when you are in the high risk area is a goggle, which full face goggle. There should be no skin visible. So either you can use a goggle or a mask with a visor, which is put outside the N95, because many times you don't get good goggles which covers the entire face. So you have to have a visor or a eyewear which covers the entire face and the forehead, a N95 mask, a head protection which is with a non-wettable disposable mask. It could be either part of a PPE suit, what we call as the hazmat suit, or any of the OT kind of a suit which has a headgear, or you will have to put a separate surgical cap mask which is disposable. And wear a full hazmat suit. Now there are different types: front zip, back zip. Ideal is to have a back zip or a back tying type. In the worst case scenario, you can even use an AMI 3 or an AMI 4 category, what we call as OT gown, as long as you make sure that your leg below the knee is covered with a separate shoe cover. So there should be, to summarize, head protection, disposable blue non-wettable cap, either as a part of the hood or as a separate cap, visor or a goggle which has no skin surface left evident, especially the forehead, a N95 mask, a gown which covers up till the neck, preferably a hazmat suit, but at least a OT gown which is non-wettable, AMI 3 or AMI 4, and a shoe cover which is non-wettable. Now, sometimes we wear two shoe covers. but the outer one should be a non-wettable plastic-based thing, so that there is no wetness that gets percolated inside.
And at the same in the same note, if somebody is inferring or referring to using ART prophylaxis, there is no role for that.
No, let me tell you, if you are treating patients in ICU and if you are treating patients and if you are going to collect specimens, the HIV protection kit does not protect you. It has only goggles, it has a plastic apron, and you wear gloves, and sometimes you wear an overshoe, sometimes you don't wear an overshoe. So that people may argue some protection is better than other no protection. I don't subscribe to it. Either you protect fully or you be aware you don't have protection. Don't go with the false security that I have a HIV suit that will protect me. Be very clear.
So you also, I think, fortunately, so far we are not in the situation like how some of the European countries are, where there is acute shortage of PPE. And as the Honorable Minister said, if we are able to procure it, I hope we don't reach that. And whatever we have already put into place, hopefully will work. But if you need to understand that, as Sir has already mentioned, a half cover is not cover. It is not going to
It be more dangerous.
or no protection.
Half cover is more dangerous.
Because in case you get exposed,
because you have a false sense of security.
Yeah. In case you get exposed to a COVID positive patient with these half gear, you will still be considered as a high risk contact. That is something you need to understand.
Any other question?
Thank you, sir. So one more question. If for general OPDs, do we need all the doctors should wear N95? Although they are not.
No need.
For general OPDs, triple layer surgical mask is good enough. Also, please remember, in a general OPD, please keep triple layered surgical mask and give it to patients whom, when you are entering, they're sneezing or coughing, please give it to them. They need it more than you. Right?
The ICMR guideline actually has very lucidly put it out very nicely. In different areas, what has to be done. It's very.
There is a tablet column. Please go to the ICMR website. It very clearly gives you in what situation, what protection should be, practiced by healthcare professionals.
Our Honorable VC has also sent to a group.
Yes.
Yeah, actually, the question has been raised by many interns and PGs. That, all of us are exposed to COVID positive patients, so we need to wear PPE. So that's not required actually. It's very clearly the guidelines are written, which area, what has to be worn, and everything it will circulate it. Please do not insist on PPE because we have to use our resources very judiciously. It will run out of stock, and then actually where it is required, it will not be available. So it's important that we use it very judiciously. Okay. Thank you.
And if we plan the resources now, if at all we hit the rainy day, we at least have something with us. Otherwise, as Sir said, we'll be in a lot of.
Any other question?
One question has come. Are ACE inhibitors with chloroquine contraindicated the combination?
No.
ACE inhibitor with
ACE inhibitors, very, very clear. The whole question was raised by Simon and Garci, who felt that if you block the ARB receptors, ACE2 receptor number will increase. Type 2 pneumocytes and ACE2 receptors are the ones that will facilitate the viral entry. This was a hypothesis. Subsequently, number of papers have come out. All societies, cardiology societies, nephrology societies, hypertension society, internationally, CDC also has clarified very, very dangerous to withdraw ACE inhibitors or ARB blockers just because of this hypothesis at this point of time. There are number of papers that are coming about lung protective effect of ARB or ACE inhibitor. Therefore, what should be borne in mind is the general precautions. Whenever there is an afferent renal vasoconstriction, depleted volume, increasing creat, we generally hold ARB or ACE inhibitor for a few days. But not because of this hypothesis.
So as far as use of HCQ is concerned as a prophylaxis, many people are purchasing over the counter. I think that is not advisable because before taking the HCQ, patient should have been gone for a ECG checkup and then ophthalmic checkup to rule out any diabetic retinopathy. Otherwise, they should not take. they have to consume under the direction of the physician.
And do not believe what the social media or WhatsApp university, as Dr. Ravi mentioned, because there is a set of what we call as GCP, good clinical practice. In that, before starting HCQ, you would at least try to get an ophthalmology opinion. The toxicity, retinal toxicity or binding of chloroquine to retinal melanin pigment and causing a pigment retinopathy may be very rare.
But you should have.
But we are seeing a large number of reported and unreported cardiac issues with indiscriminate use of chloroquine. Note that ICMR is very, very categorical and has put two groups. One, healthcare workers who are involved in SARI work. Second, close contacts of proven. And if we recall Dr. Ravi's lecture, high risk and low risk. So if there is high risk contacts, then they have to be given. And simple things may actually make things safer. One, do a simple ECG. If the RR interval, if the QTC is less than half of the preceding RR interval, it is quite safe to give chloroquine in that sense. Plan what you want to give. If there is a need for covering a patient with azithromycin, hold on to starting chloroquine.
Not to give sir.
And also, do not buy chloroquine over the counter. In US, chloroquine phosphate, which is used for aquarium cleaning purpose, was taken by couple and there is death report related to that. Therefore, please be very careful. It is a prescription medicine.
And very soon, I think we will be including chloroquine as a scheduled drug.
It's already included. It's a Schedule H drug.
It's already been gazetted.
48 hours back.
And the most important is before we take further questions, which I don't think there is many.
There are.
So none of us would be experts in COVID-19 management because this is a very dynamic space. Every day, some evidence will come in, and better to keep oneself abreast of new evidence.
For any authentic information, this team has already compiled the booklet. It will be on the website. It will be on Health and Family Welfare Government of Karnataka website. It will be on RGHS website. Kindly look for such authentic information, right from surveillance to ventilator treatment. Everything is there. So kindly look into that only and don't believe anything else.
Next question.
One question is about the safety issue of NSAIDs and ibuprofen in the COVID patients.
NSAIDs and ibuprofen.
So basically the theory is there is the prostaglandin pathway, there is the leukotriene pathway. Steroids or NSAID will affect the leukotriene pathway to some extent. There may be unregulated prostaglandins. This way may work in enhancing the viral replication or viral entry into cells. Second, if you are using paracetamol enough to combat the fever temperature regulation, I don't think in these patients who actually develop a lot of GI side effects and stress-induced GI effects, till further safety norms are established, current evidence is not to use NSAIDs.
Next question.
One more question, like how many days it will take for RT-PCR to come positive after infection?
The moment people are symptomatic, we all know after virus enters, there is an incubation period. Incubation period is up to 14 days. Having said that, majority of the patients, this is solid data from China, develop symptoms 5th day after infection, between 5th and 7th day. Once there is onset of symptoms, the PCR is almost always positive. I must tell you that PCR can be negative in nasal and pharyngeal swab 7 days after onset of symptoms because the patient has already gone into respiratory distress. At that time, the recommended specimens are if the patient is producing productively sputum, that's a good specimen. If not, bronchoalveolar lavage. For people who come into the hospital in ARDS, remember nasal and pharyngeal swab alone is not enough. You also need bowel sample to be sent to the lab. People ask me, how sensitive is PCR? The PCR that is used in India is a consensus PCR used across the world, developed by US, Chinese, and German scientists. It has been validated. It has a 95% sensitivity. That means 95% of the times it will be positive. And it has a specificity of 98%. There is no test in the world that will detect all infections. There is no test in the world that will not give false positive result. That's a dream. I've been 40 years in diagnostic work. I'm still living that dream. But remember, 95% sensitivity, 98% specificity is excellent for any test. Always clinical judgment shall prevail. If you feel you have to repeat after 2 days, please do so and make a case why your sample should be tested. Next question.
Dr. Deepak TG, you can ask, sir. Dr. Deepak T.
Yeah. Hello, panel. My question is to Dr. Sunil Karan. See, we have spoken about severe acute respiratory illness, but unusual presentations of COVID-19 have not been spoken about. Recently, we have got a few patients with acute gastroenteritis. Because of this COVID-19 outbreak, so we are always worried about that, because most of our casualty doctors will be exposed directly, even without the mask and without N95 mask. So how to go about in such patients, how to segregate, what should be the treatment protocol?
So I think we still would be going by the definition of SARI, because exclusively GI symptoms only without a travel history, less likely that it will be COVID, at least at this point of time. Yeah, it's not been reported, at least at this point of time with whatever data we have, which is largely from Wuhan. And if you look at the first two NEJM papers, about 80% had a combination of fever, respiratory, and some respiratory symptom. And that's why the SARI definition is based like that: a fever plus cough, plus or minus respiratory distress, plus history of travel, plus a couple of those things. So there is no mention made about exclusive gastroenteritis alone. So I think if somebody comes to you off the cuff, from a local area, acute GE, no history of travel, not at all having fever, there were a lot of choleras reported, a lot of other acute GEs reported. So I think that will still be treated as acute GE, and we don't have to sort of shift our focus as long as there is no combination of a fever and a cough associated with that. But again, this is changing times. As we have seen with our dengue experience 3-4 years later, what we learned in the first year may not be true. But I think for now, we would still stick to the definition of SARI and investigate on that lines.
These are minor symptoms.
And the other thing is chest discomfort or chest pain is not a unusual presentation of a patient with COVID. There's lately, I think there are some studies wherein it has shown that about 40 to 50% of the cardiologists to whom the patient has gone with the chest pain have been found to have a COVID positive. So always whenever the patient has got a chest pain, because as you know, a viral infection can cause myocarditis, can show STT changes, ECG changes, and also if the patient has got other history like exposure or travel, and if the patient has got a chest pain and you ruled out any acute myocardial infarction or any other thing, please think about COVID infection, which can cause these symptoms.
Next question.
One more question. Are the asymptomatic doctors who have done duty with their PPE in the COVID wards, they need to be quarantined, although they are asymptomatic?
If you are sure of complete protection being done and that there is no breach of your PPE protocol while doffing and donning, there is probably no need to be quarantined. Now, from a social perspective, this may be a difficult question or an answer to give, because there is always going to be, I might be worried to go back home because of my family, somebody elderly in the family, etc., etc. But I think at least if you look at the data from Wuhan and a few other countries, if the PPE protocol has been well followed, I don't think there has been any much problem with the healthcare workers getting affected. In fact, in the Chinese experience, it was the first few 2 weeks, I think, when they actually had healthcare workers getting involved because they were not knowing much about the infection. But in the later half, they have not had any healthcare worker getting infected. But Italy has a different experience. But we also should understand that Italy had run out of its PPs long ago. So I think that's something. But from a purely scientific perspective, if you're completely sure of that there's been no breakdown of PPs, you don't have to. But if symptoms develop and you have taken care of a known COVID positive, though you have maintained PPE, it may be worthwhile quarantining yourself.
And on a general line, we can share our Manipal experience. Every hospital, whenever there is a capacity for that, try to make 2 teams. One team as a standby, the other team is managing patients. If it is at taluk level, you may not have that luxury. But before doctor fatigue sets in, better to have a self quarantine for a few days while the other team works. Sir.
That is for a social cause. Suppose if you are using properly fit, as they said, of course, if people properly use, if they come in contact, I think need not be bothered.
By washing hands and doing all the things that needs infection control practice. That is more important. Theoretically, how long does it shed? How much is shed? Will it get into sanitary supply? Will it contaminate my water supply? Will I get it through public municipal water? Please don't go down that road. It doesn't take you anywhere. Every fecal matter excreted from a COVID patient is potentially infectious. Period. Take your precautions. There is no proven case of fecal-oral transmission till now. But that does not mean that it will not happen.
Yes.
I think this has come out from a recent Lancet publication. There is also an editorial which only, as Dr. Ravi said, what are the precautions when you should take from an infection control point.
That is
what has
focus
been
on that. Focus on that rather than on.
Yes. Partly will break the cycle anyway.
Correct.
Dr. Shashikant, you can ask your question. Please unmute yourself.
Good evening, sir. So, is there any added protection of wearing the triple layer mask or ordinary mask over the N95 mask?
It is not at all recommended. The more layers you put, the more you are going to handle infected material, the more chance you will get infected. Use one clear-cut mask, that is enough. Putting a second mask means you will be touching that. Again, you will be touching N95. Please don't touch too many infected things. Wear one N95, certified one, that is more than enough. An extra mask is not going to give you any extra protection.
In fact, I've seen some people wear a triple layer mask and on top of that they wear the N95. That will completely break the fitment and the seal which the N95.
And remember, it is going to get wet very fast. If you more layers you put, the moisture in your breath is going to make the whole thing wet very fast. Once a mask gets wet, water acts as a vehicle to carry the virus from outside directly into your mucous membrane. Please do not experiment what is not required.
One very optimistic question, sir. The virulence of the currently prevalent in India is less than what is there in China.
WhatsApp University tells us there are 2 strains of virus, virulent virus and less virulent virus. Italy is hit by virulent virus. India has been hit by less virulent virus. It has a mutation in the spike protein A430V. Even the amino acids they have shown. All this is nice to get a paper. I also want to publish papers. Show me a single validated study in the laboratory, in cell cultures or in experimental animals, that there are 2 types of strains, one more virulent, one less virulent. All this is theory. Keep it out of the window. Every coronavirus that you are dealing with, every patient you are dealing with has only one virus, and that is damn virulent. Period. I don't think I want to answer anything more. The more you want to subscribe to WhatsApp University, you are compromising your status in terms of protection, in terms of handling. It's a less virulent virus, and India will never get. Let us focus on what we are supposed to do and focus only on that.
Yeah.
Suppose we are exposed to high risk patients and we go into quarantine for 14 days and we are asymptomatic. After 14 days, do we have to undergo the testing?
Yes.
As per the current guideline, it is advisable to get yourself tested at the end of 14 days by getting a swab done.
Even though I am asymptomatic.
Yes.
Symptomatic, and at least you need to be free of symptoms of at least after 7 to 10 days.
See, the word asymptomatic, I want to warn all of you. It's very relative. Sneezing twice, feeling a little weak, running a mild temperature is okay for you. For me, it is not. If you probe all patients very vigorously, you will always get
The history.
some transient symptoms that have gone by. To be a patient who did not have symptoms. So if you're quarantining yourself, please jot down temperature with a thermometer at least 4 times during the time you are awake. Make a chart. If you sneeze, write down the number of times you sneezed. If you coughed, write down the number of times you coughed. I may sound silly, but overall you will say, that's asymptomatic. No, that's what I do every day. We are not interested in that. Be systematic, be meticulous. And at the end of the 14-day period, please get a swab done.
Quarantine, sir? Till we get the report?
Yes.
Yes, you should be.
Quarantine.
Yes, till you get the report.
When we are examining high risk patients or suspected to be positive patients with proper PPE, without a breach of PPE, then there is no need for quarantining, no sir, as you have told.
No need for quarantining. You can come back next day and serve society by examining more patients.
Okay. Thank you, sir.
It's just a thing when you are actually wearing the PP as a protocol, it is important that there is another person supervising you. It could be anybody. You might be the expert in putting on a PP, but it is extremely important to follow all the steps which have been described in the PP process when somebody is watching you, doffing and donning both, so that there's no breach of the PP process.
If you have time till patients come to your hospital, there are wonderful videos on YouTube. Please educate yourself. Always a prepared mind is better than an unprepared mind when it comes to wearing and removing PPE.
Exactly, I would like to.
Don't try to experiment in an emergency when a patient has come to you. Please do whatever you want to do virtually on YouTube, starting from today and complete it by tomorrow morning. There cannot be anything more important.
I want to just reiterate what Dr. Ravi said. We are lucky that we are in this phase. We have an experience. I mean, the real life situation, what has happened in China. We are lucky that we are learning from their experiences. So let us be prepared. It's always a prepared mind is much better in combating any emergencies. So let us get prepared. Let us get ourselves secured by all these authentic information that we have.
Thank you, sir. Dr. Sunil, you can ask your question. I have unmuted. Dr. Sunil.
Sir, thank you very much for the nice panel discussion. I am a psychiatrist, so there are many quarantine patients all over the places. So what is your suggestion for a psychiatrist to go and do counseling in person or in phone, or what exactly you suggest, sir?
I would say
preferably on the phone.
Digital platform, digital technologies you use.
In fact, from our experience, we meticulously reduce the number of visits into patient room or number of allied specialists coming into patient's room needs to be reduced. Therefore, any counseling could be done.
Social distancing is also for medical professionals and healthcare workers. So there are many digital platforms available, like the one we are using now. It's a Zoom-based one. Zoom is a free app. You can train your people how to use Zoom, and then you can do your counseling face-to-face, virtually, of course, not physically.
And there is a GO from the Niti Aayog which has allowed it, made it legal. So I think from a medical legal perspective, also you are
you are safe. You are covered now for telecounseling or Zoom counseling. Yeah, teleconsultation.
One more question, sir. The travel history or the contact history, is it compulsory for sampling at this stage of illness? Travel history or the contact history, is it compulsory to have?
There has been a recent change.
Any severe respiratory illness, symptomatic, also can be swabbed and tested. So I have a close index of suspicion. The ICMR testing, the criteria is already there on the form. If you are getting many ticks positive, you send a sample. Now,
and also my other request, whenever you're seeing a SARI patient you think requires COVID testing, please don't forget our old friend and old enemy, H1N1. It is very much there in the community. It is treatable. So collect another set of specimens for H1N1, please. That is still one of the commonest causes of SARI in the community.
in fact commoner than COVID at this stage at least.
So don't forget, in your anxiety to detect COVID testing, don't forget the common enemy that we have circulating in the community.
And I think we come to the end of this session. The last take-home message is this is the time where it is wiser not to carry ornaments, cufflinks, tie, watch, and other things. Leave them at home. We all do it mobile.
And also an ornament called mask. Please don't wear it from your house and go. That ornament also is like gold. Please keep it in your locker. Use it when you see patients.
And on another sobering note, I think we from Manipal Hospital and Narayana, we are very grateful to Honorable Vice Chancellor, Dr. Nagaraja, head of Rajiv Gandhi Chest Diseases, the virology scientist and head Dr. Ravi. This is a perfect example of private and public partnership. The need of the hour is without standing grounds that I am private, I am public. Every doctor needs to come in, pool resources, share common platforms and work to overcome this nasty pandemic. We wish you all safe, next 3 months, and thank you again.
And before we sign off, let me thank all of you.